today on patients at risk. Listen in to testimony from me and Dr. Phil Schaffer before the South Carolina Senatorial Subcommittee on Healthcare. The South Carolina Legislature has introduced several bills for this upcoming session regarding scope of practice. There's a bill that would allow unsupervised practice to nurse practitioners after 2,000 hours of experience, and a separate bill allowing the same for physician assistants. There is a bill that would expand pharmacist privileges. On the flip side, there's also a bill that would enhance team-based care, ensuring that physicians remain in the lead of medical care and strengthening requirements and enforcement of physician oversight. Today, you'll hear just a small part of the very, very long 2 days of testimony. Dr. Phil Schaffer and I were invited by the South Carolina Medical Association, and we were asked specifically to focus on data. We were told that the chair of the committee has a very strong interest in data, and we were asked to explain what evidence we have to support independent practice or unsupervised practice for NPs and PAs. The short answer is we don't have much, if any, at all. So take a listen to our testimony, and at the end, you'll hear a few questions from legislators. I also want to take a minute to encourage you, if you are a South Carolina physician, you need to know that your medical association is working so hard to make sure that you remain the leader of the healthcare team. I really encourage you, if you're not already a member of the South Carolina Medical Association, please don't wait any longer. Go ahead and join. If you can't participate in activities like testifying, at a minimum, your financial support of the organization really makes a difference in them being able to fight for you. I've worked with quite a few medical associations over the last few years, and I was just incredibly impressed with how seriously the SCMA leadership is taking this issue. They are not going down without fighting. So please make sure that you show them your support.
Excuse me, it's combined Dr. Schaffer and Rebecca Bernard. Do you have us together?
We'll take you together.
If that's okay. Thank you so
Dr. Schaffer
much.
and Dr.
Rebecca Bernard.
Thank you, ma'am.
Yes, thank you so much, Chair and members of the committee, for the opportunity to testify today. I'm Rebecca Bernard. I'm a family physician in Florida, and I'm here because I'm the author of 2 published books on scope of practice with a combined 1,000 citations between them, and I'm joined by a South Carolinian physician who helped me with that data research.
I'm Dr. Phil Schaffer from Macon, South Carolina. I'm a radiologist who's practiced for 40 years. 9 of those were in research and clinical work at an academic medicine. I'm a board member of Physicians for Patient Protection. Our organization exists to inform people about the value of physician-led care. I'm here to share the information I've gathered with you, and given the lateness of the hour, I promise to make this the most exciting data review you have ever heard.
The purpose of our presentation today is to carefully examine the evidence that you have been presented with by the South Carolina Nurses Association in support of their claim that nurse practitioners can effectively and safely care for patients without physician supervision. We'll show you a closer look at the data to show that that evidence is not actually supported. And just to be very clear, I want to make it known that we very much support the work of nurse practitioners and physician assistants working in physician-led care teams. And in fact, the data has shown over the last 50 years that they can provide very high-quality care, but that's when working in physician-led teams. And that's a caveat that's really important, but you're often not getting that information when you're hearing from advocates. The truth is that virtually every study on nurse practitioner and physician assistant care has involved some degree of physician oversight. And even with that oversight, most of these studies have always involved narrow, low-risk scenarios, minor or self-limited conditions, stable patients, and situations in which the diagnosis has already been made. What we do not have, and what is conspicuously missing, despite decades of unsupervised practice in many states across the country, is a single high-quality randomized controlled trial showing that nurse practitioners or PAs can practice safely and effectively without physician involvement. You're going to hear much more from our colleagues about the difference between physician and nurse practitioner education. I just want to touch on it briefly because it's relevant to the data we're going to show. You've already heard it takes at least 7 years to become a primary care physician, and that's about 15,000 hours. For nurse practitioners, they may graduate with a minimum of 500 hours. The average is 686 hours for a family nurse practitioner. And the reason why it takes doctors so long to get that training is the hard part, which is learning how to make a diagnosis. If you don't have the right diagnosis, you can't possibly come up with the correct treatment. So when a brand new patient comes in with a medical complaint and we don't know what is causing it, we call that an undifferentiated patient. That means that we don't have a diagnosis. So just a simple example, imagine a patient coming in with a sore throat. If you're a clinician with not too much experience, let's say an intern or a nurse practitioner, you may have the first 3 things that pop into your mind are the most common causes of sore throat. Maybe it's a virus, maybe it's a bacteria like strep throat, or maybe it's not an infection, maybe it's an allergy. So if you've only done a few years of training, those may be the first things that pop into your mind, and you may be correct. But if you've done a lot more training, you start thinking about a lot more diagnoses, less common, but potentially deadly causes. You have lots of viruses, not just cold viruses, but a variety of others. Imagine herpes virus, you wouldn't treat that the same way. You have bacteria, not just strep, but a number of other bacteria that wouldn't respond to the same antibiotic that strep would. And then you have a number of other potential causes, even going down as far as malignancy or cancer or autoimmune disease. If you haven't gone to school for a lot of years, then you can't even begin to think of all of those additional causes beyond those top 3. They say that the eye does not see what the mind does not know. So that's why school is so long for a physician, because you need to study all of those different potential diagnoses. Once you've started to think about those, you start to rule in or rule out what those causes are. And you do that by, of course, you heard history, physical exam, and then you start thinking about whether or not you need diagnostic testing like labs or imaging. And most importantly, what you need to know is whether it's a case that requires immediate and urgent attention. So one of the things that you need to know about the studies that have been done with NPs and PAs is that they never ask whether or not the NP or PA can properly diagnose a patient, meaning somebody with an undifferentiated complaint that is coming in for the first time with a potentially serious issue. They don't measure their ability to manage high-risk, acutely ill patients without physician involvement. And yet, legislation that would allow independent practice wouldn't just be for those minor issues that have been studied, but rather for all sorts of problems, no matter how complex or how ill the patient. So I'm going to show you what I'm talking about as we get into the data. And I want to start by showing you heard someone mention the Cochrane Library. Cochrane is one of the most important researchers because they are known to be non-biased and very good quality. And they published a study in 2018 looking at whether or not nurses could take on the role of primary care physicians. And you can see from their summary what they say is that the conclusion, nurses can probably provide equal or probably even better quality care compared to primary care physicians and probably achieve equal or better health outcomes for patients. That sounds great. In fact, if you take that at face value, you ask yourself, well, why do we need medical school or residency, and why did I become a family physician if a nurse practitioner can do my job as well or better? Well, there's a lot more to the story. Cochrane, that's produced that conclusion, looked at 18 papers. First, they looked at all the data. They tried to find out what did the data say about nurse practitioners in primary care. They found nearly 9,000 studies. Of 9,000 studies, just 18 were of sufficient quality to assess whether or not nurse practitioners were able to practice primary care. Of those 18 studies, just 3 were performed in the United States, 3 in Canada, and the rest outside of North America. The first study, the most important and the best study that they found, Cochrane, was by Hamani in 1999. 450 VA patients that were 100% supervised by a physician. And the study wasn't looking at how well the nurses did, it was looking at how much they spent, how much they cost the system. And the final conclusion of that study in a primary care setting, nurse practitioners may utilize more health resources than physicians.
In this study, the nurses ordered many more of the expensive imaging tests than did the physicians. The authors speculated that this was because they were inexperienced. People who are inexperienced dealing with unknown situations want to not miss anything. They will resist not ordering things. Experienced physicians know when it's appropriate to not order something.
Right. The next study in the United States was by Lewis in 1967. It looked at 66 patients only, and it wasn't looking at quality. It was simply asking, would patients be willing to see a nurse practitioner? The answer was yes. That was included in this study. The third is by Mary Mundinger. She's very well known. I call her the godmother of nurse practitioner practice because she's been a fierce advocate, and her study is very famous. It's been cited over 1,400 times in the medical literature. She published a paper in 2000 that claimed that primary care outcomes were the same for nurses and for nurse practitioners. Again, the caveat is that these were low-risk, previously diagnosed patients among nurse practitioners with extra special training and physician mentorship. Just as an example to know what she studied, she looked at 1,300 Hispanic women in their mid-40s with one stable condition, either hypertension, diabetes, or asthma. She looked at them again in 6 months, and she found there was no significant differences in outcomes. But we wouldn't expect any differences in healthy, relatively healthy people over a 6-month period of time.
I'd like to expand upon this study. The nurses in the study, and this is what you find out when you really dig into the literature. The nurses in this study were not standard nurse practitioner graduates with 2 years of book work, and about 500 hours of clinical work. They were actually Columbia University teaching faculty who had many years of experience. They were given an extra 9 months of teaching, she said, was just like residents. In other words, they were on the floors for an extra 9 months. This wasn't disclosed in the original article. It should have been as part of standard scientific etiquette, but it wasn't. It was found in a YouTube video that she gave 14 years later. In this YouTube presentation, Mundinger said they knew these experienced nurse practitioners had to have more education to compete with the physicians, and therefore they had to give the nurse practitioners an extra 9 months to catch up. The nurse practitioners had physician oversight throughout the study, and also Cochrane noted that the bias in the study is the highest of any of the studies they reviewed. Something else that was not in this article that we found that was critical was that Mundinger had the most serious conflict of interest I've ever seen in a scientific paper. She was actually on the board of directors of United Health Group, the largest employer of MPs in the United States. She did not disclose this conflict of interest in the paper, and had she done that, it might not even have been published.
Those were the only 3 United States studies that were included in that conclusion. Then we have some Canadian studies from the 1970s, and the Burlington trial is one of the most important ones because back in 1974, just like today, primary care physicians were overworked, and so they asked if they could maybe bring in their nurses, give them more training, and have them help out. And they found that indeed nurse practitioners working side by side with physicians, caring for low-risk patients, were as good as a physician 55 to 67% of the time. Chambers likewise had a similar report with side-by-side working together. Venning in 2000 looked at nurse practitioners in a walk-in clinic, 100% supervised. They found that nurse practitioners required direct assistance from a physician 17% of the time. The study was not powered sufficiently to determine whether or not that care was cost-effective.
I'd like to add a few comments here. As Dr. Bernard pointed out, these patients were only followed for 2 weeks. This is entirely inadequate to determine if the care that we've given was adequate or not. The endpoints don't address medical care. They were economic and marketing endpoints such as patient satisfaction. And note here, the authors tell us directly that their results do not relate to nurse practitioners who are working independently. I want to recycle back this to the conclusion that Cochrane made about the entire study and the nurse practitioner care being equal or perhaps better than physician care. Questions we are considering today is that of independent practice, and this article specifically states it can't be used to judge that.
You're going to see the same sort of things happening here. United Kingdom studies included in the trial. 2 of them were just telephone triage, showing that nurses could do a great job. Telephone triage, a study from Schum at looking at minor medical complaints, again, finding that 27% of nurse practitioners' patients required evaluation by the physician. A supervised study showing that nurse practitioners could do a great job following protocols to manage chronic conditions. A few specialty studies, which is interesting considering that this was a primary care article, but showing that patients that were stable and well controlled could be followed by a nurse practitioner. Interestingly, the second study by Chan looked at mild dyspepsia, which is just upset stomach, with patients that had already had an endoscopy and were not high risk, finding that the nurse practitioners could do a good job in follow-up. So this is not nurse practitioners making independent diagnoses or dealing with any type of acutely ill patient. 3 studies in the Netherlands, 2 of which were protocol-based, and actually 2 of which were considered inadequate to assess quality. A study in South Africa, nurse practitioners following protocols. A study in Sweden, nurse practitioners following protocols. And then finally, the last of the 18 studies was one in Spain, a walk-in urgent care clinic, 100% supervised, found nurse practitioners could manage 72% of minor burns, injuries, and diarrhea without a physician, but they could only manage 17% of low back pain, 16% of colds, and 15% of urinary symptoms independently. So I took you through the 18 best studies in the literature as of 2018 examining the safety and efficacy of nurse practitioners in primary care. And again, to reiterate, 100% physician supervised, following physician-created protocols, eliminating or excluding high-risk or complex patients. And so to say that this is safe and effective, to extrapolate to real-world patients, that is a very large stretch.
So we've taken it through the studies one by one. We'd now like to reorganize the data a little bit for clarity, and we'll do this by looking at individual questions that you would like to ask. The first question is, did the MPs see new patients in these studies? And in 8 studies, the MPs were not allowed to see new patients. The next question is a critical one, and that is, and how many of these studies were the nurses' diagnoses examined? And in none of the 18 studies did the NPs have their ability to diagnose examined. So it's inappropriate to use this to support totally unsupervised care. The next question is, were the nurses' treatment plans examined? In 1 of 18 studies was the nurses' treatment plan examined. Then a question you might not think to ask, were ill patients excluded from the nursing group? And in 15 studies, the MPs were not allowed to see patients who were actually ill. Another interesting question is how many MPs were in each study. 5 of these studies had 1 or 2 MPs, okay? And these MPs clearly in their institution would have been selected for being the best MPs they had. It's entirely inappropriate to try to extrapolate a study of 1 or 2 individuals to 300,000 MPs in the U.S. We've mentioned algorithm following, which is basically the physician sets up a plan and can the nurse follow it, like continuing high blood pressure medicine. In 10 of the 18 studies, the MPs were only tested on their ability to follow the algorithm. Another question which bears upon our points of team care is that in 17 of the 18 studies, it was a physician-led team practice model. So Lawrence's statement said probably equal or possibly even better quality of care than primary care physicians. And if you're someone who wants to go to the data to see how or to answer this question, you're probably like all of us, you're short on time. So you read the summaries and you trust the authors to produce a correct summary. However, in this case, if you actually read the papers, the original papers, you find there's nothing at all to support such a statement.
Just to take a look at some more recent articles, I have pulled some of them from the AANP's website that is used to justify independent practice. This study from Zhao, which they say shows that NP prescribing practices are comparable to that of physicians, but they don't mention that that's in physician-led care teams. If you go to the actual report by Zhao, you see here that they say this is a physician-based sample. It only represents NPs and PAs working in physician practices, and that the data is not informative on independent practice. Likewise, you can see another report from 2021. It shows strong quality of care by NPs, but the caveat in physician-led care teams with low-risk patients. They used a lot of the same data that you heard in Cochrane, but one of the new studies they pulled is from Kennersley in 2000, and I have a screenshot here showing that patients in that study that were too ill were removed from the data, and further that physicians were always involved in the care to prescribe when necessary. When it comes to mental health, that's something that I'm very concerned about here in South Carolina and in my state of Florida, because these are our most vulnerable patients. So here's a study that claims that NPs provided similar care to physicians when it comes to mental health, but actually the study report says that the quality is very poor. So you have some data, but the quality is just not adequate to decide whether it's safe for our patients. You'll hear about this study because it's pretty recent. Inappropriate prescribing, saying that nurse practitioners were no more likely than physicians to inappropriately prescribe. This has to do with medicines on something that's called the Beer criteria. These are medicines that are not highly recommended for seniors, although sometimes we use them because it may be the best case for that patient. So it's not a perfect study, but they claim that there was really no difference. Well, if you look at the report, you see that on average it was about the same, but nurse practitioners were actually overrepresented among the highest rates of inappropriate prescribing. And who are those nurse practitioners? Are they the ones that are practicing independently, or are they less experienced? We don't know because the study doesn't tell us that. And actually, we really don't know how many NPs even are practicing independently or even want to. The most recent data I could find from 2021 found that 3.9% of NPs in full practice authority states were self-employed. Now, many NPs don't talk about this, and one of the reasons is because they've been discouraged from speaking out. This is a screenshot from the American Association of Nurse Practitioners closing ceremony in 2019. It's a smiley face with a zipper for the mouth, and it says the strongest voice is silent. And they have advised nurse practitioners, if you do not agree with full practice authority, you need to stay quiet. And in fact, they have a reporting link where you can report. So I really give a lot of credit to any nurse practitioner who feels that they want to work with physicians who is willing to speak out, because it is not something that is very easy for them to do. Now, regarding the small number of nurse practitioners who own their own clinic, we don't have a ton of data, but we're starting to see some malpractice evidence come out. This is from 2022. It's a closed data claims, and they found that nurse practitioner-owned clinics had the highest rate of malpractice claims, with the number significantly increasing from 2017 to 2022. The number one reason for the claim was failure to properly diagnose, and the number one claim cause was death. So you know that there's evidence, but you know that it's not necessarily great, so you're basically taking a chance. Here, for example, the VA published data in 2014 when they were considering allowing independent practice. They showed in their data that there was no difference in outcomes, but they acknowledged that the strength of the evidence ranged from insufficient to low, but they decided to go ahead and allow nurse practitioners independence anyways. And Dr. Batson already presented this information, but 10 years later, what we're starting to see is higher cost of care and poorer outcomes.
We want to discuss the data you've heard today, that the claim that states with independent practice have better health outcomes in general. This, plainly said, is poor research. Papers claiming this show only correlations. They don't and cannot claim independent practice laws cause better health outcomes. In other words, it's not possible to conclude that from these papers that if you pass independent practice laws, then your state's health will improve. Here's the most recent paper published with this claim. We've reviewed it. It's the same as the others, correlation, not causation. There are numerous factors that weigh into a state's general health. Here are listed some of them, and on the bottom I include unsupervised practice of medicine in that state. This paper tried to say that unsupervised practice of medicine was the only cause responsible for better health. However, they excluded all the others and didn't look at all those other potential causes of health. Keywords, when you're looking at papers to see if they're correlation and not causation, keywords to watch out for are related to or associated with, such as factor A is associated with factor B. This paper uses the words associated or association 61 times, the words related or relationship 12 times. It uses the word cause 0 times. In fact, buried inconspicuously in the last page of the paper is a sentence that directly states the reader should not assume that full practice authority caused the better outcomes. They also note that there are other factors they have not considered, such as the state's general health policies.
You're being asked to make a large assumption that if something is safe and effective with supervision, that it's safe and effective without supervision. We just don't have that data. I've shown you the flaws in the nurse practitioners' reporting, but just to be aware of some of the data that's out there in the medical literature showing that compared to physicians, NPs and PAs do order more tests, including labs and imaging, more medications, including 20 times more inappropriate opioid prescribing in independent practice states. They prescribe more antipsychotics to children than physicians, more unnecessary antibiotics. They have lower quality and more frequent referrals, and more likely to unnecessarily biopsy but then miss melanoma in situ, and certainly some concerns about cost. One thing to be aware of, I've heard it said that more access is the answer, but more access doesn't mean better outcomes. This is a brand new headline from New Mexico showing that they've had a recent significant increase in their number of psychiatric nurse practitioners, and yet their behavioral health system their outcomes are incredibly poor. They're not improving at all. It's important also, you heard it mentioned that most physicians are now employed, and the trend that we're seeing across the country is physicians being replaced, and in many cases it's for cost savings. So what is happening is not just our physicians losing access in rural areas and underserved areas, but even in cities and suburbs.
Yes, we need our nurses. I think we all are aware that there's a critical shortage of bedside nurses. There are multiple factors responsible for this shortage. However, one article written by the nursing faculty has noted that there's a dramatic increase in the number of NPs being produced, which is responsible for reducing the size of registered nurse working force by up to 80,000 nationwide. The production of nurse practitioners, and one might say the overproduction of nurse practitioners, has come at the cost of reduced numbers of bedside nurses, exacerbating the shortage of bedside nurses.
We believe that South Carolina patients deserve high-quality, cost-effective medical care, and the data is clear that physician-led care teams are the best. Thank you so much for indulging this long presentation, and we'd be happy to take any questions.
Thank you so much, Dr. Bernard, Dr. Schaffer. Questions for either Dr. Schaffer or Dr. Bernard in regard to this excellent presentation? Senator from Orangeburg.
So even though independent practice may not cause higher health outcomes in those other states, you don't have any evidence to say it diminished it, do you?
It's such a great question because, as I mentioned in the beginning, we don't have any data at all on any of this. We've had independent practice, let's say out in Alaska and Washington State for 30, 40 years. So where is the data examining whether it's safe and effective? And I'm very curious to know why that hasn't been produced. It seems like a lot of times they say, well, they're going to solve the problems. We're going to allow independent practice. And then people kind of wash their hands of it. And we haven't seen any real data or follow up on that.
You supervise nurse practitioners?
I have in my past jobs, but not currently.
You're available for 6 right now. How about you?
Well, I'm a radiologist, so we don't directly interact with nurse practitioners much, indirectly some.
But you about to be out of a job because the AI bots are going to run you out.
We can have a nice discussion about that over beer.
You can program these machines to outread a human every time, I guarantee you. But anyway, I too thank y'all for being here. But will y'all be willing to work to see if we can come up? There must be some amount of training and experience that a nurse practitioner could have that would allow them to go across the road or 20 miles away and open up and understand what their scope was and understand when they saw something that they just couldn't do, and they'd send them right back to you.
Thank you so much for asking that question. In 1910, the Flexner report came out.
I'm old, but 1910?
1910. And it was a really big deal because there was a time that physicians were trained in an apprenticeship model. There was some years of school, wasn't that great. There was a lot of these sort of diploma mills. They didn't call them that then, as we do today. And then after you worked with a doctor for a certain amount of time, because it wasn't going to be a woman back then, he signed off on you and you were set free. In 1910, Abraham Flexner went all around and looked at all those schools and found out that they were doing a horrible job, that these doctors were coming out unprepared and were not in any way should be taking care of patients. That began medical reform so that that's no longer allowed. Doctors cannot apprentice their way into becoming a physician because it doesn't work, it's not safe, and it's not effective. So if it's not safe or effective for physicians, it's not safe or effective for anyone. There is a path to becoming independent. Medical school and residency, and I have spoken with many physicians who were NPs or PAs and decided to go back to med school and residency, and they have told me over and over again, I didn't know what I didn't know. I was not safe. I was not ready, even those who have practiced for a while.
Senator Zell.
Yes, sir. Just real quick. Is there any possible way we could get that presentation emailed to us?
I think that's possible.
Yes.
Thank you so much, doctors.
Thanks so much for listening. I hope you enjoyed this episode. We'll probably bring you some more of that testimony as we go through it if you're interested. So if so, shoot me an email. Let me know what you think. You can message me through the Patients at Risk website. That's patientsAtRisk.com. Of course, if you're a physician, I would always encourage you to join our advocacy work through the group Physicians for Patient Protection. You can learn more at our website, physiciansforpatientprotection.org. Thanks so much, and we'll see you on the next episode.